Hi everyone, and welcome to 𝘵𝑒𝑡ococcus. In this series, we'll explore key renal topics that are frequently tested on the USMLE Step 1. If your exam is coming up soon, these high-yield videos will help you master essential concepts. Let's dive right in and ensure you're well prepared to tackle renal system questions on Step 1. First, let's look at a clinical case. A 47-year-old man presents to the emergency department a week after starting ampicillin for bacterial sinusitis. He has developed fever, a diffuse maculopapular rash, and reports low urine output. Laboratory findings show elevated creatinine, 2.4 milligrams per deciliter, and his urinalysis reveals 𝖵𝖲𝑬𝐬𝑐 with 3 to 5 eosinophils per high-power field. This presentation is highly suggestive of acute interstitial nephritis. Medications like antibiotics, including beta-lactams, sulfonamides, or non-steroidal anti-inflammatory drugs, proton pump inhibitors, and diuretics are all common culprits. It's important to recognize that the clinical features of acute interstitial nephritis often include fever, rash, and acute kidney injury, all of which are present in this patient. Now, what exactly is going on here? Well, acute interstitial nephritis is a hypersensitivity reaction that primarily affects the renal tissue between kidney tubules, leading to inflammation and edema. This patient's kidney injury is likely due to a drug reaction, specifically from ampicillin, a beta-lactam antibiotic commonly implicated in acute interstitial nephritis. Now, how exactly does this damage occur? Acute interstitial nephritis is caused by a type 1 hypersensitivity reaction involving IgE-mediated or cell-mediated type 4 mechanisms. This leads to infiltration of the renal interstitial tissue by eosinophils, lymphocytes, and macrophages. This process disrupts the normal kidney function, resulting in decreased glomerular filtration rate and signs of acute kidney injury like we see in this case. Now let's move to the next case. A 65-year-old man comes in with a 2-day history of low-grade fever and rash. He has no other systemic symptoms, but he started taking indomethacin for gout 10 days ago. His serum creatinine is elevated at 2.3 milligrams per deciliter, and his urinalysis shows numerous white blood cells. This, again, points us towards acute interstitial nephritis induced by non-steroidal anti-inflammatory drugs. So, what are the common laboratory findings? You'll see features of acute kidney injury with elevated creatinine, 𝖵𝖲𝑬𝐬, and the presence of white blood cell casts. Another hallmark finding is eosinophiluria, detected by special stains like Hansel or Wright stain. In this case, the diagnosis was made clinically based on drug exposure and characteristic symptoms. Next, let's look at another case to drive this point home. A 46-year-old man presents with recurrent joint pain. He was started on allopurinol 2 months ago and now reports malaise, nausea, and a faint maculopapular rash. His creatinine has risen from 1.1 to 2.2 milligrams per deciliter, and his urinalysis shows WBC casts and eosinophils. Once again, we're looking at a classic case of drug-induced acute interstitial nephritis, this time caused by allopurinol. This highlights an important takeaway. Drug-induced acute interstitial nephritis accounts for 75% of acute interstitial nephritis cases. And always keep an eye out for new medications like antibiotics, non-steroidal anti-inflammatory drugs, and proton pump inhibitors in patients presenting with acute kidney injury. Okay, let's wrap things up. Acute interstitial nephritis should be on your radar anytime a patient presents with fever, rash, and acute kidney injury, especially following recent medication use. Look for eosinophiles in urine, 𝖵𝖲𝑬𝐬, and WBC casts in the lab findings. The mainstay of treatment is to discontinue the offending drug, and in some cases, glucocorticoids may be used if symptoms persist. Now let's move to the next high-yield case. This one involves a 27-year-old man who presents with fever, joint pain, and dark urine after starting cephalexin for a skin infection. His temperature is 38.5, and his labs show 8 RBCs and 12 WBCs per high-power field, along with white cell casts, eosinophils in the urine, and mild proteinuria. His serum creatinine is 2.2, and BUN is 40. What should be the next step in management? The correct answer here is to discontinue cephalexin. This patient has developed drug-induced acute interstitial nephritis, a hypersensitivity reaction commonly triggered by drugs like penicillins and cephalosporins. Key clinical features include fever, rash, arthralgia, and eosinophiliuria, along with white blood cell casts in the urine. The first-line treatment is to stop the offending drug. Let's dive right into the next high-yield topic, acute pyelonephritis. A 33-year-old woman who is 34 weeks pregnant arrives at the emergency department with a fever, nausea, vomiting, and right flank pain. She has no significant medical history, and her pregnancy has been smooth so far. She's admitted to the hospital with acute pyelonephritis and is started on intravenous ceftriaxone. After 48 hours, she shows significant improvement, is now fever-free, and is able to resume a normal diet. Her vital signs are stable with normal temperature, blood pressure, and pulse, and her abdomen is non-tender. A urine culture from the day she was admitted reveals 𝐻𝐸𝐴 coli, with the following antibiotic sensitivities. The urine culture shows 𝐻𝐸𝐴 coli with sensitivities to various antibiotics. The bacteria is sensitive to cephalexin, fosfomycin, nitrofurantoin, and trimethoprim sulfamethoxazole. However, it is resistant to ciprofloxacin. Based on these results, cephalexin is the most appropriate oral antibiotic for this patient. So, what's the most appropriate oral antibiotic for this patient? The correct answer is cephalexin. This case highlights a common scenario in pregnant patients who are at an increased risk of acute pyelonephritis due to pregnancy-related urinary tract changes, such as ureteral dilation, which allows bacteria to travel up to the kidneys. 𝐻𝐸𝐴 coli is the most common bacteria, responsible for around 70% of cases. And notice that pregnant women with pyelonephritis require hospitalization and intravenous antibiotics to prevent complications like preterm labor or acute respiratory distress syndrome. Once the patient is stabilized after 48 hours, she can be switched to an oral antibiotic to complete the treatment. In this case, cephalexin is the best option. It's a first-generation cephalosporin that is safe for use during pregnancy and effective against the identified strain of 𝐻𝐸𝐴 coli. After completing the treatment, a follow-up urine culture is necessary due to the risk of persistent infection, and prophylactic antibiotics may be considered for the remainder of the pregnancy to prevent a recurrence. Next, we have a 45-year-old man who presents to the emergency department with a 2-day history of right flank pain, fever, and chills. He reports dysuria and increased urinary frequency. He's running a fever with a temperature of 38.7, while his blood pressure is normal and his heart rate is slightly elevated. On physical exam, there is right costovertebral angle tenderness. Urinalysis shows leukocytes, white blood cell casts, and bacteria, which confirms a diagnosis of acute pyelonephritis. The patient is started on a fluoroquinolone, which is a common choice for treating complicated urinary tract infections like pyelonephritis. Now, the simple question asked is how fluoroquinolones works. Simply, these antibiotics, such as ciprofloxacin, target DNA gyrase, which also known as topoisomerase II in bacteria. DNA gyrase is responsible for relieving the positive supercoils that form during DNA replication. By inhibiting this enzyme, fluoroquinolones prevent the bacteria from properly replicating their DNA, which leads to bacterial cell death. This is an essential high-yield point for the USMLE Step 1 exam, one that frequently appears in test questions and is critical for understanding key mechanisms in pharmacology and microbiology. Okay guys, let's now discuss asymptomatic bacteriuria in pregnancy significantly increases the risk of acute pyelonephritis. That requires immediate attention. In this case, we have a 31-year-old woman who is 28 weeks pregnant and presenting for her initial prenatal visit. She mentions feeling fatigued, but doesn't report any major concerns. Importantly, She has no symptoms of a urinary tract infection, such as pain with urination or increased frequency. However, her urine culture shows the growth of more than 100,000 colony-forming units of Escherichia coli, confirming the diagnosis of asymptomatic bacteriuria. Now, why is this important? Asymptomatic bacteriuria in pregnancy is not a condition we can ignore because it carries a significant risk of progression to acute pyelonephritis if left untreated. In fact, acute pyelonephritis is the greatest risk for this patient if the bacteriuria is not addressed. Pyelonephritis is a serious infection of the kidneys that can lead to further complications like preterm labor, acute respiratory distress syndrome, and low birth weight. So, why does ASB increase the risk of pyelonephritis in pregnancy? The simple answer is that during pregnancy, elevated levels of progesterone lead to smooth muscle relaxation and dilation of the ureters. This allows bacteria to ascend from the bladder to the kidneys, increasing the likelihood of developing an infection in the renal parenchyma. Escherichia coli, the organism found in this case, is the most common culprit. So, what should be done next? Given that all pregnant women are routinely screened for asymptomatic bacteriuria at their first prenatal visit, the next step for this patient is to initiate appropriate antibiotic therapy. First-line options for treatment include fosfomycin, cefpodoxime, or amoxicillin clavulanate. Once the treatment is completed, it's important to follow up with a urine culture to confirm the infection has been fully eradicated and to prevent any potential recurrence. The main concern here is the potential progression to pyelonephritis, which can severely impact both maternal and fetal health if not managed appropriately. So, to wrap things up, asymptomatic bacteriuria in pregnancy significantly increases the risk of acute pyelonephritis. This makes early screening and treatment critical for preventing complications like preterm labor and respiratory distress syndrome. Make sure to thoroughly review these cases as they frequently appear in exams. If you have any questions or need clarification, feel free to leave a comment below and I'll respond as soon as I can. Good luck with your studies. Thank you for joining this episode of the Metacoccus video series. Stay tuned for more high-yield discussions on topics that frequently appear in your NBME and USMLE exams.